Welcome to the deep dive. Today we're doing a serious plunge into one of the most vital and, let's be honest, incredibly intricate systems in the human body, the cardiovascular system. If you ever tried to get a handle on heart conditions, the sheer volume of information out there can feel, well, like trying to learn a whole new language in a single sitting.
Oh, absolutely. It's a real challenge. Every condition, every diagnostic test, every nuance seems to branch off into a dozen more.
Yeah.
It's definitely easy to get lost.
Exactly. So our mission today is to be your expert guides, if you will. We've gone through stacks of articles, research papers, our own notes, and we've tried to distill them down.
Right, to the most important nuggets of knowledge and insight from this vast world of cardiology.
Our goal is to equip you with a thorough yet truly digestible understanding of heart conditions, from the really common ones to some pretty surprising complexities.
Yeah, we promise clear explanations, memorable details, those aha moments that hopefully make the information stick. We're trying to cut through the noise so you can feel genuinely well-informed, all delivered at a pace that respects your time.
All right, let's unpack this. We're kicking things off with understanding ischemic heart disease. Basically, what happens when the heart muscle isn't getting enough blood flow? Think of it as a spectrum, right? From the subtle whispers of angina or chest pain, all the way to the thunderclap of a myocardial infarction, a heart attack.
That's a great way to put it. The term ischemic heart disease covers this whole broad issue. And within that, you've got acute coronary syndromes, ACS, which are those sudden, severe forms, like unstable angina or a heart attack itself.
Okay.
And the most serious is a STEMI, ST elevation myocardial infarction. That's where a major coronary artery is completely blocked. And it creates this really distinct signal on an EKG. It's a true medical emergency. Needs immediate action.
Speaking of heart attacks, our sources highlight these 9 modifiable risk factors. But here's where it gets really interesting and maybe counterintuitive for a lot of people listening. Dyslipidemia.
Right, that unhealthy balance of cholesterol and fats.
It's actually cited as the single most important risk factor, even more so than high blood pressure.
Yeah, and it's fascinating why that is.
Yeah.
Dyslipidemia really takes the top spot because it's the primary driver of atherosclerosis, that process where plaque builds up in your arteries.
And narrowing and stiffening.
Exactly. It's like rust in a pipe, just slowly constricting the flow. It sets the stage for a heart attack. So while hypertension definitely strains the heart, dyslipidemia is more directly responsible for building the roadblocks in the first place.
That distinction really helps put it into perspective. So tackling cholesterol is, well, foundational.
Absolutely.
Now, while dyslipidemia is huge for heart attacks, are there other risk factors that maybe disproportionately affect other heart-related conditions?
Oh, for sure. Tobacco use, for instance. It's a major contributor to plaque buildup generally, but it's particularly significant for peripheral arterial disease, PAD.
The vessels outside the heart and brain, like in the legs.
Precisely. And this also brings up an important point about screening. Lipid screening, it seems, is often most beneficial for younger individuals, say, under 35 for men, under 44 for women, if they have those additional risk factors.
Like diabetes, hypertension, or smoking history.
Exactly. It's all about targeted prevention in those cases.
So if you're younger, generally healthy, maybe no screening needed right away, but if you've got those other flags, definitely worth a closer look. Okay, let's talk chest pain. It's the classic symptom, right? But how do we dissect it? Because not all chest pain means heart attack.
That's such a critical point. We look for typical angina, often described as pressure, tightness behind the breastbone, usually provoked by exertion or stress.
And relieved by rest or nitro.
And importantly, relieved by rest or nitroglycerin. It's a predictable pattern. That contrasts with atypical chest pain, which might have some, but not all of those features. And then you have to differentiate it from positional or pleuritic pain.
Pain that changes with breathing or position.
Right, what you might feel with pneumonia or pericarditis, that inflammation of the heart sac, the story, the characteristics of the pain, they really guide us.
Which brings us straight to diagnostics, the first absolutely critical step when someone shows up with chest pain.
UKG, you got to get that done fast.
Right, looking for those immediate signs, like a STEMI.
Indeed. Then, if the diagnosis isn't immediately clear from the EKG in the story, we often move to stress testing.
Okay.
The idea is simple. Make the heart work harder and see if it shows signs of stress, revealing blockages that might not be obvious when resting.
So an exercise EKG if they can handle it?
Exactly, if a patient can safely exert themselves and has a normal resting EKG. But if they can't exercise, or maybe they have certain EKG abnormalities already, like a left bundle branch block,
Then you use drugs.
Then we turn to pharmacologic stress tests, using medications like adenosine or dobutamine that basically simulate exercise for the heart.
And if all signs are pointing to a high probability of coronary heart disease, or the stress test itself shows really concerning features,
Like significant EKG changes. Then we move to coronary angiography.
the roadmap you mentioned.
Exactly. It's more invasive, sure. Dye is injected right into the heart arteries so we can visualize them directly, see exactly where the blockages are. It's typically reserved for when we really need that detailed picture to guide decisions, like about stents or bypass surgery.
Okay, so someone comes in with an acute STEMI. You said it's a race against time to save heart muscle. What are those immediate, crucial interventions?
Prompt action is absolutely key. It's like a cascade of things happening fast. Oxygen, but only if their saturation is low, actually.
Oh, interesting. Not always needed.
Not always, no. Nitrates can help open blood vessels, but you use them cautiously, right? If blood pressure is already low, or if it's a specific type of heart attack affecting the right side, or severe aortic stenosis.
Got it.
Crucially, antiplatelet therapy starts immediately. Aspirin plus another agent, usually a P2Y12 blocker like ticagrelor or clopidogrel, to prevent more clotting.
And anticoagulation.
Also initiated, usually with heparin. And beta blockers are used to reduce the heart's workload unless contraindicated by things like overt heart failure or a very slow heart rate.
And the absolute #1 priority in all this.
Restoring blood flow to that blocked artery as quickly as humanly possible.
So the stent procedure, PCI.
Ideally, yes. Percutaneous coronary intervention, PCI, within 90 minutes of first medical contact, or maybe 120 minutes if they need transferring to a specialized center. Speed is muscle. And statin therapy is started as soon as possible, too, to help stabilize any remaining plaque.
It's all about that speed and precision, saving that vital heart muscle. But what happens after the immediate crisis? Complications post-MI, they're a real concern, aren't they?
They really are. The heart muscle, it's weakened, damaged. It can face several mechanical complications. One major one is a papillary muscle rupture.
Which messes with the valve.
Exactly. It can lead to acute, severe mitral valve leakage, mitral regurgitation, and rapid onset fluid in the lungs, pulmonary edema. Then there's a ventricular septal rupture, or VSR.
A hole between the chambers.
A hole forms between the heart's main pumping chambers, the ventricles. Blood shunts inefficiently, puts huge strain on the heart. You can sometimes detect a step up in oxygen levels between the right atrium and right ventricle.
Wow.
And then there's free wall rupture. That's catastrophic. It leads to a rapid buildup of blood around the heart.
Tamponade, you said that's like the heart being squeezed from the outside?
Precisely. Imagine the heart is a pump inside this sac, the pericardium. If that sac fills rapidly with blood, the heart can't expand to fill properly. It essentially squishes the heart, prevents it from pumping. Very dangerous. Another one is a left ventricular aneurysm.
Scar tissue.
Basically, yeah. A scarred, weakened area of the heart wall. You can sometimes identify it by persistent EKG changes, like ST elevation that just doesn't go away, and deep Q waves.
And then there's stent thrombosis, which sounds like exactly what it is, a clot forming in the stent.
You got it. Stent thrombosis usually presents like another heart attack, often within that first month after the stent is placed. And the biggest risk factor, premature discontinuation of that dual antiplatelet therapy.
So sticking to the meds is absolutely crucial after a stent.
Cannot emphasize that enough.
Okay, moving beyond the acute stuff, let's talk about managing chronic stable angina. For people with that persistent, predictable chest pain with exertion, what's the long-term game plan?
For long-term management, beta blockers are typically first line. They just reduce the heart's workload, slow it down a bit.
Okay.
If they're not enough, or if the patient can't take them for some reason, calcium channel blockers, CCBs, are often used next.
And
nitrates provide that quick relief, and they can also help prevent angina if taken before exertion. But, and this is important, you need those drug-free intervals, usually overnight.
to avoid tolerance.
Exactly. The body gets used to them otherwise.
And I've heard of ranolazine as an interesting option. What's special about that one?
Ranolazine is quite unique, yeah. It works differently. It reduces the heart muscle's oxygen demand without significantly affecting heart rate or blood pressure, unlike many other anti-anginal drugs.
Ah, so it's another angle of attack.
Precisely. Makes it a valuable add-on or alternative when other treatments aren't quite cutting it. Offers a different way to ease that chronic chest pain.
Okay, statins. Pretty much everyone's heard of them. But beyond just they lower cholesterol, what are the broad indications and what else should we know?
Statins are truly cornerstone medications for cardiovascular risk reduction. Broadly indicated for anyone with established atherosclerotic cardiovascular disease. So if you've had a heart attack, stroke, PAD.
You're on a statin.
Pretty much, yeah. Also for those with very high LDL cholesterol levels, 190 milli-GDL or higher, regardless of other risks. And most individuals with diabetes aged 40, 75 should be on one.
And they do more than just lower the numbers, right?
Absolutely. They have important anti-inflammatory effects. They stabilize those plaques in the arteries, make them less likely to rupture and cause that acute event like a heart attack or stroke.
And the side effects. People always worry about muscle pain.
Myalgia, muscle pain, it's a common concern, sure, affects a small percentage of patients. But the risk of the really severe muscle breakdown, rhabdomyolysis, is actually very low, like 0.1%.
Tiny.
Very low. So while we monitor for symptoms, of course, the overall cardiovascular benefits of statins generally far outweigh these risks for most people.
What about drug interactions, especially with other heart meds?
Yeah, that's important. A key one is amiodarone, a common antiarrhythmic drug. It can interfere with the metabolism of certain statins, like simvastatin and atorvastatin, potentially increasing their levels and side effects.
So you might need to switch statins.
Often, yes. If a patient's on amiodarone, rosuvastatin is frequently a preferred choice because it's metabolized differently. And here's a vital point that sometimes gets lost.
Okay.
While statins can slightly increase the risk of new-onset diabetes in some patients, the huge long-term protection they offer against major cardiac events, heart attacks, strokes, is so significant that this small, usually manageable increase in blood sugar risk is a trade-off that overwhelmingly favors heart health.
That's a crucial insight, understanding that balance of risks versus benefits. Okay, let's get specific about antiplatelet therapy. We mentioned dual antiplatelet therapy, GAPT, earlier for stents. How long is that typically needed, and why is it so critical?
So DAPT, usually aspirin plus a P2Y12 blocker, is absolutely crucial for preventing clots from forming inside that new stent. It's usually recommended for 6 to 12 months after placement.
Longer sometimes for the drug-eluting stents.
Often longer for drug-eluting stents, yeah. The exact duration really depends on balancing the individual patient's bleeding risk against their risk of stent thrombosis. It's a personalized decision.
And what about when a patient on DAPT needs surgery? That sounds like a really tricky situation.
It is. It's a major balancing act. For elective surgery, the ideal scenario is definitely to postpone it until that minimum DAPT duration is completed, just to minimize bleeding risk during the operation.
But if it's urgent?
If urgent surgery is necessary, the general approach is to continue the aspirin unless the bleeding risk is exceptionally high, and hold the P2Y12 inhibitor for the shortest possible time. It's a very carefully weighed decision involving the cardiologist and surgeon.
And for bypass surgery, CABG?
Specifically for CAG, those PDY12 inhibitors must be discontinued 5 to 7 days beforehand because of the high bleeding risk associated with that specific procedure.
And I've heard there's something specific about PPIs, those proton pump inhibitors for acid reflux interacting with clopidogrel.
Yes, that's right. Omeprazole, which is a very common PPI, can inhibit an enzyme, CYP2C19, that's needed to activate clopidogrel. So it potentially reduces its effectiveness.
Making the antiplatelet less strong.
Exactly. So if a patient needs a PTI while on clopidogrel, pantoprazole is generally preferred because it has less impact on that specific enzyme. It's a good example of how seemingly unrelated medications can have these important interactions.
Definitely. All right, let's shift gears now. Heart failure and cardiomyopathies. Getting into how the heart's pump function itself can go awry. How do we even define heart failure, and what's a key distinction we need to make?
Yeah, so heart failure isn't that the heart just stops working, right? It's that it can't pump enough blood to meet the body's needs effectively. And the really key distinction is between heart failure with reduced ejection fraction, HFrEF,
The HFrEF.
HFrEF, and heart failure with preserved ejection fraction, HFpEF. HFpEF. Think of it like this. In HFrEF, the heart muscle is weakened. It can't squeeze effectively, so less blood gets ejected with each beat.
Lower ejection fraction number.
Exactly. In HFpEF, the heart muscle is often stiff, thickened. It can't relax properly to fill with enough blood between beats, even though the squeeze, the ejection fraction, might look normal or near normal.
Ah, so a filling problem versus a squeezing problem.
That's a great way to summarize it. And it's a crucial distinction because the management is quite different.
So how do we get diagnostic clues, especially when someone comes in short of breath? How do you know if it's heart failure and maybe which type?
BNP and NT-proBNP levels are incredibly useful here. These are hormones the heart releases when it's under stress or stretched.
Okay.
Elevated levels strongly suggest a cardiac origin for symptoms like shortness of breath. helps us distinguish heart failure from, say, lung problems like COPD or pneumonia.
Now, for acute decompensated heart failure, someone comes in really struggling, maybe fluid overloaded, having trouble breathing. What's the immediate action plan?
Initial management is all about stabilizing them quickly. We give supplemental oxygen if needed. Intravenous diuretics are first line to rapidly get rid of that excess fluid.
Lasix, for example.
Furosemide, yeah. And vasodilators like IV nitroglycerin are often used, especially for that flash pulmonary edema you see sometimes in patients with okay blood pressure. They help reduce the workload on the heart, open things up.
And if they're really sick, low output.
If there's severe decompensated HF with very low output, meaning the heart just isn't pumping enough blood forward to perfuse the organs, then we might use inotropic agents. Things like milrinone or dobutamine, they help improve the heart's contractility, the squeeze.
But they have risks.
They do. Milrinone, for example, can cause low blood pressure and arrhythmias, so they're used cautiously, usually in an ICU setting.
That's the acute picture. What about chronic HFrEF management, the long game? It sounds like there's some real cornerstone medications here.
This is where we focus on medications that have shown a clear mortality benefit, meaning they help people with HFrEF live longer, healthier lives.
The big guns.
Exactly. These include ACE inhibitors, or ARBs, or the newer ARNIs like valsartan and sacubitril. And specific beta blockers, not just any beta blocker, but ones proven in heart failure trials, like metoprolol, flexonate, carvedilol, or bisoprolol.
Okay.
Diuretics, as we said, are mainly for symptom control, managing fluid. And then aldosterone antagonists like spironolactone or eplerenone are also really important. They add mortality benefit for patients with lower ejection fractions or post-MI with HF and diabetes. But you absolutely have to monitor potassium levels and kidney function with those.
Risk of hyperkalemia. And there's a specific combination sometimes used, especially for certain patient populations.
Yes, the combination of hydralazine and isosorbide dinitrate, it's shown particular benefit for African-American patients who still have symptoms, despite being on those other cornerstone meds. Digoxin also still has a role.
The old classic.
The old classic, yeah. It primarily helps reduce hospitalizations by improving symptoms, but it doesn't actually improve mortality, unlike the others we mentioned.
With all these powerful meds, side effects are obviously a big consideration. What about that classic ACE inhibitor cough everyone asks about?
Ah, yes, the ACE inhibitor cough. It's pretty common, usually a dry, irritating cough. It's thought to be related to bradykinin buildup. More seriously, though less common, is angioedema.
The swelling.
That swelling, often of the face, lips, tongue, also bradykinin-mediated. And interestingly, in severe acute cases of ACE inhibitor-induced angioedema, giving fresh frozen plasma can actually help because it contains an enzyme that breaks down bradykinin.
Wow, didn't know that. And digoxin toxicity. What should listeners be aware of if they or someone they know takes digoxin?
Digoxin toxicity can be subtle or severe. Look out for loss of appetite, nausea, vomiting, confusion, sometimes visual changes, like seeing yellow-green halos or weird color vision, and it could definitely cause various heart rhythm disturbances, bradycardias, or tachycardias.
Is there an antidote?
Yes, for life-threatening toxicity, we have digoxin-specific antibody fragments, often called Digifab or Digibind. Very effective.
What about combining ACE inhibitors and ARBs? Intuitively, it sounds like hitting that system twice would be better, but I've heard it's generally not recommended.
That's a great point, and you're right. Dual blockade of the renin-angiotensin system, using both an ACE inhibitor and an ARB together, does not offer a significant mortality benefit over using an ACE inhibitor or ARB alone, and importantly, it significantly increases the risks of hyperkalemia, that high potassium and hypotension, low blood pressure, and kidney injury.
So, more risk than benefit.
Generally, yes, so it's not recommended routine practice.
Now, heart failure with preserved ejection fraction, HFpEF, you said the management is quite different here compared to HFrEF.
It is, because the fundamental problem in HFpEF isn't usually the squeeze, it's the filling, that stiffness. So, management focuses primarily on controlling blood pressure very tightly, managing heart rate, often to allow more filling time, and carefully managing fluid volume with diuretics to relieve congestion.
What about beta blockers? They're key in HFrEF.
Right, but unlike HFrEF, beta blockers haven't shown a broad mortality benefit in HFpEF unless there are other specific reasons to use them, like controlling AFib rate, or if the patient also has coronary artery disease, ischemia. So it's really about optimizing the conditions for that stiff heart to fill as best as it possibly can, treating the contributing factors.
Okay, let's explore cardiomyopathies beyond the basics, starting with dilated cardiomyopathy, where the heart becomes enlarged and weakened. What are some common causes?
A really common cause of dilated cardiomyopathy is myocarditis inflammation of the heart muscle itself, often triggered by a viral infection. And interestingly, unlike after a heart attack where aspirin is key, there's no role for aspirin as an antiplatelet agent in myocarditis generally.
Good to know. Any other specific types?
There's peripartum cardiomyopathy. This develops late in pregnancy or in the months after delivery. The heart becomes weak, ejection fraction drops below 45%. For these women, especially if their heart function doesn't fully recover after delivery, future pregnancies are often advised against because the risk of recurrence or worsening heart failure is quite high.
Wow, that's tough. Then there's hypertrophic cardiomyopathy, HCM.
Huh.
I always associate this with, unfortunately, sudden cardiac death in young athletes.
Sadly, yes. It's a common cause of sudden cardiac death in seemingly healthy young people, especially athletes. HCM is characterized by an abnormally thickened heart muscle, the hypertrophy. Often it's asymmetric, meaning one part of the ventricle wall is much thicker than others, typically greater than 15 millimeter.
And the heart sounds are distinctive.
Very distinctive. The classic murmurs associated with the outflow obstruction in HCM actually get louder with maneuvers that decrease the amount of blood in the heart, like standing up quickly or doing the Valsalva maneuver, bearing down.
Because there's less volume to push the obstruction open.
Exactly. And the murmurs get softer with maneuvers that increase the heart's filling volume, like squatting or clenching fists hard, hand grip. This is really key to diagnosing it at the bedside.
So how is HCM managed?
Beta blockers are first-line therapy. They slow the heart rate, which allows more time for the stiff ventricle to fill, and that can reduce the outflow obstruction. Critically, diuretics are generally harmful in HCM because reducing the preload, the filling volume, can actually worsen the obstruction.
Opposite of typical heart failure treatment?
And patients with specific risk factors for sudden cardiac death, like massive heart muscle thickening, say over 30 millimeters, or unexplained fainting spells, a strong family history of sudden death, or runs of non-sustained ventricular tachycardia on monitoring, have a strong indication for an implantable cardioverter defibrillator, an ICD.
The internal defibrillator.
Yeah, exactly. A device that can shock the heart back into rhythm if a life-threatening arrhythmia occurs. And very importantly, competitive high-intensity sports should generally be avoided.
Finally, under cardiomyopathies, restrictive cardiomyopathy, or RCM, where the heart muscle becomes stiff and rigid but not necessarily thick like in HCM.
It can be thickened, but the primary issue is the stiffness, the lack of compliance. RCM is often caused by infiltrative diseases, things like amyloidosis, where abnormal proteins deposit in the heart muscle, or sarcoidosis, an inflammatory condition.
Any diagnostic clues for RCM?
A really powerful diagnostic clue, particularly in cardiac amyloidosis, is something called mass voltage discrepancy on the echo and EKG. Meaning the echocardiogram shows significantly increased heart muscle mass that looks really thick, but the electrical signals on the EKG, the QRS voltage, are paradoxically low or weak. It's like seeing a huge muscular person with a very faint heartbeat signal, highly suggestive of amyloid infiltration.
It's incredible how many different ways the heart muscle itself can cause problems. Let's switch gears to arrhythmias. When the heart beats out of time. First, what about palpitations, that feeling of your heart fluttering or racing, and syncope, which is fainting? How do you figure out the cause when someone passes out?
Evaluating syncope really depends on the patient's risk profile and how often it happens. If there are high-risk features like injury during the faint or known heart disease, they need immediate evaluation, often hospital admission and telemetry monitoring.
And for less frequent episodes.
For infrequent events, say less than one episode per month, or when the cause remains unclear after initial tests, implantable loop recorders offer a much higher diagnostic yield than shorter-term Holter monitors. They can continuously record the heart rhythm for years, potentially catching that rare arrhythmic cause.
What about common causes like vasovagal syncope?
Neurocardiogenic or vasovagal syncope is very common. Often has a classic trigger prolonged standing, emotional stress, sight of blood, and usually preceded by warning signs, like feeling lightheaded, sweaty, nauseous before passing out.
And carotid sinus hypersensitivity, you mentioned that earlier?
Yes, this is a condition usually in older adults where even slight pressure on the carotid sinus area in the neck can trigger a profound slowing of the heart rate and a drop in blood pressure, leading to syncope. It can be diagnosed with a careful carotid sinus massage during monitoring, but again, you have to be cautious and avoid it if there's known carotid artery disease.
Moving to heart blocks, which ones are considered high risk and usually need a permanent pacemaker?
Certain types of AV block, the electrical signal delay between the atria and ventricles, are high risk because they have a significant chance of progressing to complete heart block, where the signals don't get through at all. This can cause dangerously slow heart rates or even pauses.
Which types specifically?
These high-risk blocks include Mobitz Type 2 AV block, 2.1 AV block where every other beat is blocked, and complete heart block itself. Even if the patient isn't having symptoms at that moment, these generally require a permanent pacemaker implantation due to the risk of sudden, severe bradycardia or asystole.
And some medications can cause block too.
Definitely. We mentioned beta blockers and calcium channel blockers, but others too, like digoxin, amiodarone, and even drugs like donepezil used for Alzheimer's disease, can sometimes induce bradycardia or heart blocks. Always review the med list.
How about supraventricular tachycardia, SVT, that really fast but regular rhythm from above the ventricles, and atrial flutter? How are they managed acutely?
For SVT, the first step is often trying vagal maneuvers, things like bearing down as if having a bowel movement or blowing into a syringe, or sometimes a clinician might do a careful carotid sinus massage. These can stimulate the vagus nerve and sometimes break the SCT circuit.
And if that doesn't work?
If vagal maneuvers fail, the first-line drug for most common types of SVT is intravenous adenosine. It works very quickly but briefly to block the AV node. If SVT is recurrent and problematic, catheter ablation is often the preferred long-term solution, offering a potential cure.
What about atrial flutter? Adenosine works for that too.
Actually, no. Adenosine is not effective for terminating atrial flutter acutely, though it can sometimes slow the ventricular response down temporarily, making the flutter waves easier to see on the EKG. For long-term rhythm control of flutter, radiofrequency ablation is highly effective, often considered first line.
And if a patient with flutter is unstable?
If unstable, meaning very low blood pressure, altered mental status, chest pain due to the fast rate, then immediate synchronized cardioversion and electrical shock is necessary to restore normal rhythm quickly.
And Wolff-Parkinson-White, or WPW syndrome? Sounds complex, and you mentioned distinctive EKG findings.
They are pretty distinctive. WPW involves an extraelectrical pathway, an accessory pathway, connecting the atria and ventricles, bypassing the normal AV node delay. This causes a pre-excitation pattern on the EKG.
The short PR and delta wave.
Exactly. You see a short PR interval, that characteristic slurring at the beginning of the QRS complex called a delta wave, and often a widened QRS overall. Catheter ablation, which finds and eliminates that extra pathway, is the preferred first-line treatment, especially for symptomatic patients or those in high-risk jobs like pilots or bus drivers.
And you mentioned a critical warning about using certain drugs in WPW if they also have AFib.
Yes, this is incredibly important. If a patient has both atrial fibrillation and underlying WPW, using AV nodal blocking agents, that's beta blockers, calcium channel blockers, specifically for apomildidiazem, adenosine, and digoxin, is absolutely contraindicated.
Why is that so dangerous?
Because blocking the AV node, the normal pathway, can preferentially shunt all those rapid atrial impulses down the fast accessory pathway directly to the ventricles. This can lead to incredibly rapid ventricular rates, potentially degenerating into ventricular fibrillation, which is cardiac arrest.
Wow, that's a crucial point. All right, let's tackle atrial fibrillation, or AF, which is so incredibly common. What are some typical underlying causes or triggers we should think about?
Oh, many things can trigger AF or make it worse. Common culprits include underlying heart disease like hypertension or heart failure, but also acute issues like severe infection, sepsis, low oxygen levels, hypoxia, pulmonary embolism, an overactive thyroid, hyperthyroidism, excessive alcohol intake, holiday heart, or even major surgery.
So you look for a reversible cause.
Always look for and treat any underlying triggers.
And what's the general strategy for managing AF long term? Is it better to just control the heart rate or try to restore and maintain a normal rhythm?
That's the classic rate versus rhythm control debate. For many patients, particularly older adults, say over 65, or those with established heart failure or minimal symptoms, a rate control strategy is generally preferred initially.
Why is that?
Because the antiarrhythmic drugs used for rhythm control can have significant side effects, including the risk of proarrhythmia actually causing new, potentially dangerous arrhythmias. So, rate control with agents like beta blockers or calcium channel blockers for epimildidiazem is often safer and achieves similar outcomes in terms of mortality for many patients.
But before you try to shock someone back into rhythm, cardioversion, you need to worry about clots.
Absolutely critical. If AF has been present for more than 48 hours, or the duration is unknown, and the patient hasn't been adequately anticoagulated, there's a significant risk of a blood clot being present in the left atrial appendage. Cardioversion could dislodge that clot, causing a stroke.
So you need an echo first.
So you either need to ensure adequate anticoagulation for at least 3-4 weeks before cardioversion, or perform a transesophageal echocardiogram, a TE, right before the procedure to definitively rule out a clot in the appendage.
Makes perfect sense. How do you assess that stroke risk in AF patients to decide who needs anticoagulation?
We use a clinical risk score called the CHA2DS2 VAS score. It incorporates factors like age, sex, history of hypertension, diabetes, stroke, vascular disease, and heart failure to estimate the annual stroke risk. Based on the score, we decide on anticoagulation.
And comparing the anticoagulants, warfarin versus the newer ones.
Compared to warfarin, the direct oral anticoagulants, or DOACs, drugs like apixaban, rivaroxaban, dabigatran, and doxapan, generally have similar or slightly better efficacy at preventing ischemic stroke. But importantly, they have significantly lower rates of major bleeding, especially life-threatening intracranial hemorrhage.
So DOACs are usually preferred.
They are generally preferred for most patients due to their safety profile and convenience. No routine monitoring needed. However, warfarin is still the preferred agent for patients with severe chronic kidney disease, say an eGFR less than 30 LL-min, or those with mechanical heart valves.
Good distinction. And ablation for AF.
Catheter ablation for AF is also an important option, particularly for patients with recurrent symptomatic AF despite medication therapy, or sometimes as a first-line therapy in select patients, especially younger ones who want to avoid long-term medication.
Okay, finally, under arrhythmias, let's touch on the really dangerous ones. Ventricular arrhythmias and sudden cardiac death, SCD. For ventricular tachycardia, or VT, that fast rhythm from the lower chambers, how is it managed?
Management depends heavily on whether the patient is stable or unstable. If they're stable, meaning conscious, with reasonable blood pressure, intravenous antiarrhythmic medications like amiodarone, lidocaine, or procainamide can be used to try and terminate the VT.
And if unstable?
If the patient is unstable, low blood pressure, shock, unconscious, then immediate synchronized cardioversion is the treatment. Don't delay.
And that specific scary-looking one, torsades de pointe, TDP.
Torsades de pointe, which means twisting of the points, is a specific type of polymorphic VT where the QRS complexes seem to twist around the baseline on the EKG. It's almost always associated with a prolonged QT interval on the baseline EKG.
And the treatment is specific.
The immediate treatment is intravenous magnesium sulfate. Even if the patient's magnesium level is normal, IV magnesium helps stabilize the cardiac membrane. And critically, you need to identify and stop any offending agents that might be prolonging the QT interval.
What causes that QT prolongation commonly?
It can definitely be congenital, inherited, but acquired causes are much more common. Electrolyte abnormalities are big ones. Low potassium hypokalemia, low magnesium hypomagnesemia, sometimes low calcium hypocalcemia. And importantly, a lot of medications can prolong the QT interval.
Like what kinds?
Numerous categories. Certain antibiotics, especially macrolides like azithromycin and fluoroquinolones, many antipsychotics, antidepressants, antiemetics like ondansetron, and ironically many antiarrhythmic drugs themselves like sotalol, dufetilide, and amiodarone. Always have a high index of suspicion and check that med list and electrolytes.
Good advice. And when it comes to actually preventing sudden cardiac death, what's the most critical intervention during an active cardiac arrest?
During cardiac arrest, by far the most important predictor of survival is early, high-quality, uninterrupted chest compressions. That C in CAB, chest compressions, airway, breathing, is paramount. Push hard, push fast, minimize interruptions.
And for long-term prevention in high-risk individuals, we mentioned ICDs.
Right. Implantable cardioverter defibrillators, ICDs, play a crucial role. Indications fall into two main categories: primary prevention and secondary prevention.
Explain those.
Primary prevention is placing an ICD in patients who are in high risk of SCD but haven't had a life-threatening arrhythmia yet. This typically includes patients with significantly weakened hearts, like an LVEF of 30-35% or less, usually measured sometime after a heart attack, or with established cardiomyopathy, NYHA Class 3 symptoms. Secondary prevention is placing an ICD in someone who has already survived a cardiac arrest due to ventricular fibrillation, VF, or unstable ventricular tachycardia, VT, that wasn't caused by a clearly reversible factor, like an acute MI.
Got it. I've also heard of something called Brugada syndrome. What's that?
Brugada syndrome is a fascinating inherited electrical disorder of the heart. It's more common in men, particularly of Southeast Asian descent. It can cause syncope or sudden cardiac death, often during sleep or rest. It has very specific EKG findings, a characteristic coved ST elevation in the right precordial leads, V1, V3. Finding this pattern, especially with symptoms, is a strong indication for ICD placement due to the high SED risk.
And one last connection: obstructive sleep apnea, OSA, and arrhythmias.
Yes, there's a strong link. Untreated OSA is associated with a variety of nocturnal cardiac arrhythmias episodes happening during sleep. These can include significant bradycardia, slow heart rate, pauses, non-sustained VT, and particularly atrial fibrillation. The repetitive oxygen desaturation and sympathetic surges during apneic events are thought to trigger these. And importantly, treating the OSA with CPAP therapy can often significantly reduce or even eliminate these arrhythmias.
So treating sleep apnea is actually cardiac risk reduction.
Absolutely. It's an often underappreciated factor.
Okay, let's turn our attention now to valvular heart disease. This is where we really start listening closely to the heart's sounds, the murmurs. What are some general principles to keep in mind when you're listening with a stethoscope?
A key principle, maybe the most important one, is that diastolic murmurs, those happening during the heart's relaxation or filling phase between S2 and S1, are almost always abnormal. If you hear one, it needs investigation.
Okay, diastolic, abnormal. What about systolic murmurs?
Systolic murmurs happening during contraction between S1 and S2 are much more common and can sometimes be benign, like flow murmurs. However, systolic murmurs that are loud, say grade 3 out of 6 intensity or greater, or those that last throughout systole, holosystolic, or occur mainly in late systole, also warrant further investigation, usually with an echocardiogram. Basically, loud, long, or late systolic murmurs, and any diastolic murmur raise a red flag.
Globally, rheumatic valve disease is still a huge issue, isn't it? What's a common valve problem it leads to, and how is recurrence prevented?
Yes, unfortunately, rheumatic heart disease remains a major cause of valve problems worldwide, though less common now in developed nations. The most common long-term consequence of rheumatic fever is mitral stenosis, narrowing of the mitral valve. The key prevention strategy, especially in areas where rheumatic fever is still endemic, is continuous antibiotic prophylaxis, often with long-acting penicillin injections, to prevent recurrent group A strep infections, which trigger the rheumatic process. This limits progression of valve damage.
Okay, let's break down mitral stenosis MS itself. What does that narrowed mitral valve sound like, and what are the implications?
Classic auscultation findings for MS include a loud first heart sound, S1, often an opening snap shortly after the second heart sound, S2, as the stiff valve opens, and then the characteristic murmur. A low-pitched, rumbling diastolic murmur, best heard at the apex of the heart with the bell of the stethoscope, often with the patient rolled onto their left side and holding their breath after expiration.
That's quite specific.
It is. It reflects the turbulent blood flow struggling to get from the left atrium into the left ventricle through that narrowed valve. A major complication is left atrial enlargement due to the pressure backup, which strongly predisposes to atrial fibrillation. And AF in the setting of MS carries a very high risk of systemic thromboembolism, forming clots in that enlarged atrium that can travel to the brain, causing a stroke. So anticoagulation, specifically with warfarin, is crucial for AFib in MS patients.
How is MS treated?
For patients with symptomatic moderate to severe MS, if the valve morphology looks suitable on echo, not too calcified or distorted, the preferred treatment is often percutaneous mitral balloon valvotomy, PMBV. It's a catheter-based procedure to stretch the valve opening, less invasive than open heart surgery.
Shifting over to the aortic valve now, aortic stenosis. AS. This seems like a really common problem, especially in older adults.
It is definitely one of the most common valve lesions in the elderly and developed countries, often due to calcification of the valve leaflets over time.
What are the classic findings for AS?
Auscultation typically reveals a harsh crescendo-decrescendo systolic murmur. It gets louder towards mid-systole, then softer, usually heard best in the aortic area, right upper sternal border, and often radiating up into the carotid arteries in the neck. You might also hear a soft or absent second heart sound, A2 component, and sometimes an S4 gallop due to the stiff left ventricle.
And the pulse.
On physical exam, a classic finding in severe AS is parvus et tardus, carotid pulses, meaning the pulse feels weak. Parvus and delayed tardus, compared to the heartbeat, because the blood flow is obstructed getting out of the ventricle.
How do maneuvers affect the AS murmur?
Maneuvers that decrease preload or venous return, like the strain phase of Valsalva or standing up suddenly, will typically soften the murmur of AS. Conversely, maneuvers that increase afterload, like squatting or sustained hand grip, tend to make the murmur louder or longer, though this can be variable.
So what's the prognosis once someone develops symptoms from AS?
This is critical. The prognosis for severe AS becomes very poor once symptoms develop. The classic triad is angina, syncope, fainting, and heart failure dyspnea. Once these appear, average survival without valve replacement drops dramatically, often measured in just a few years. This makes aortic valve replacement, AVR, essential for symptomatic severe AS.
So symptoms are key for intervention. What about asymptomatic patients?
For asymptomatic patients with severe AS, management involves close monitoring with serial echocardiograms. AVR is generally indicated even without symptoms if there's evidence of left ventricular systolic dysfunction, LVEF 50%, or if the patient is undergoing other cardiac surgery like CABG, or sometimes based on very high valve gradients or concerning stress test results.
And its counterpart, aortic regurgitation, AR, where the aortic valve leaks backward into the left ventricle.
Right. AR is characterized by diastolic leakage. The classic murmur is an early decrescendo diastolic murmur. It starts right after S2 and fades out. It's typically high-pitched and blowing, best heard along the left sternal border, especially with the patient leaning forward and holding their breath in full expiration. You might also hear other associated sounds like an Austin Flint murmur.
How is AR managed? When do you replace the valve?
Similar to AS, AVR is indicated for symptomatic patients with severe AR. For asymptomatic patients, surgery is generally recommended if there's evidence of LV dysfunction, LVEF dropping below 50%, or significant LV dilatation, enlargement beyond certain thresholds like an end systolic dimension 50-55 millimeter or end diastolic 70-75 millimeter, because waiting too long can lead to irreversible LV damage.
Can medications help?
Vasodilators like ACE inhibitors or nifedipine can be used to reduce the regurgitant volume and afterload in patients with severe AR who have symptoms or LV dysfunction but are not surgical candidates, but they don't replace the need for surgery when indicated.
Okay, back to the mitral valve. Mitral regurgitation, MR, the leaky mitral valve, and mitral valve prolapse, MVP, where the valve leaflets bulge back into the atrium.
MVR typically causes a holosystolic murmur, meaning it lasts throughout systole, from S1 to S2, best heard at the apex, and often radiating towards the left axillary armpit. MVP is often characterized by a mid-systolic click, which is the sound of the prolapsing leaflet snapping taut, sometimes followed by a mid to late systolic murmur if there's associated regurgitation.
How do maneuvers affect the MVP click and murmur?
This is classic. Maneuvers that decrease venous return and LV volume, like standing up or Valsalva strain, make the click occur earlier in systole and the murmur become longer, because the ventricle is smaller and the prolapse happens sooner relative to the start of contraction. Maneuvers that increase LV volume, like squatting, make the click later and the murmur shorter.
How is significant MR managed?
For severe MR, surgical mitral valve repair is generally preferred over replacement whenever technically feasible, as it often leads to better long-term outcomes and preserves LV function better. Surgery, repair or replacement, is indicated for symptomatic patients with severe MR or asymptomatic patients who develop evidence of LV dysfunction, like an ejection fraction dropping below 60%, or the LV end systolic dimension getting larger than 40 millimeter, or new onset AFib or pulmonary hypertension.
Can meds slow down MR progression?
That's a really important point. Unlike some other valve conditions, currently no medication has been definitively shown to delay the need for surgery or slow the progression of chronic primary MR itself. Management focuses on monitoring and timely surgical intervention.
That's critical information. What about patients who already have prosthetic heart valves? They require special consideration, especially for anticoagulation.
Absolutely. This is vital. Patients with mechanical prosthetic heart valves require lifelong oral anticoagulation with warfarin. The target INR range depends on the valve type and position, typically 2.0, 3.0 for aortic valves, and a higher range of 2.5, 3.5 for mitral valves or older caged ball type valves, or if there are other risk factors. Aspirin is often added as well.
What about bioprosthetic valves, the tissue valves?
Bioprosthetic valves made from animal tissue, porcine or bovine, are much less thrombogenic. They typically only require anticoagulation with warfarin for the first 3 months after implantation, while the valve leaflets endothelialize. After that, aspirin alone is often sufficient, unless there's another indication for anticoagulation like AFib.
And finally, under valves, a rare but fascinating one, cardiac tumors. Anything specific we should know?
The most common benign primary cardiac tumor by far is a cardiac myxoma. About 80% of them occur in the left atrium.
How do they present?
The presentation can be quite varied, often called a triad. 1. Constitutional symptoms like fatigue, low-grade fever, weight loss, mimicking infection or inflammation. 2, systemic embolization, where pieces of the often gelatinous tumor break off and travel, causing TIAs, strokes, or blocking arteries elsewhere. 3, and perhaps most classically, signs of intracardiac obstruction, often position-dependent.
Position-dependent.
Yes, the tumor is often on a stalk and can flop around, potentially obstructing the mitral valve intermittently. So a patient might have symptoms like fainting or shortness of breath that only occur in certain body positions, and you might hear a diastolic murmur, like mitral stenosis, that changes or even disappears when the patient changes position, sometimes called a tumor plop sound. Diagnosis is usually via echocardiography, and prompt surgical resection is the definitive treatment due to the risks of embolization and obstruction.
All right, let's move into congenital heart disease in adults. These are conditions people are born with, but they might only cause issues or be discovered later in life. Starting with atrial septal defect, ASD, specifically the common secundum type, that hole between the upper heart chambers.
Right, a secundum ASD is one of the more common congenital defects diagnosed in adulthood. Characteristic physical exam findings include a wide, fixed splitting of the second heart sound, S2, meaning the split doesn't vary with breathing like it normally does, and often a mid-systolic pulmonary flow murmur due to the increased blood flow across the pulmonary valve.
What about the EKG?
The EKG often shows right axis deviation and an incomplete right bundle branch block pattern due to the right ventricular volume overload.
What are the long-term risks if it's not closed?
Complications can include the development of atrial arrhythmias, like AFib or flutter, paradoxical embolization, where a clot from the veins bypasses the lungs through the ASD and causes a stroke, and eventually pulmonary hypertension and right heart failure if the shunt is large and long-standing.
So when should an ASD be closed? Is it based on size?
The primary indication for closure, usually done percutaneously with the device these days, isn't solely the size of the defect itself, but rather the presence of symptoms attributable to the ASD or objective evidence of significant right-sided cardiac chamber enlargement, right, atrium or ventricle, on echocardiography, indicating significant shunting.
Then we have patent ductus arteriosus, PDA, where that fetal blood vessel connecting the aorta and pulmonary artery fails to close after birth.
A PDA creates a continuous shunt of blood from the high-pressure aorta to the lower-pressure pulmonary artery. The classic presentation is a continuous machinery-like murmur heard best below the left clavicle. You might also find a wide pulse pressure, difference between systolic and diastolic BP, and bounding peripheral pulses due to the aortic runoff.
Complication.
Similar to large shunts like VSD or ASD, potential complications include left heart volume overload, leading to heart failure, pulmonary hypertension, and in severe, long-standing cases, the development of Eisenmenger syndrome, where the pulmonary pressures become so high that the shunt reverses direction, right to left.
When is closure indicated?
Closure, usually percutaneous, is indicated if there's evidence of left-sided chamber enlargement due to the volume overload or if symptoms develop. However, closure is absolutely contraindicated if severe pulmonary hypertension with shunt reversal, Eisenmenger syndrome, is already present, as closing the PDA in that situation could worsen right heart failure and be detrimental, even fatal.
Next, ventricular septal defect, VSD, a hole between the two main pumping chambers, the ventricles.
VSDs vary greatly in size. Small VSDs might only cause a loud murmur, but no significant hemodynamic issues, and can sometimes close spontaneously. Larger VSDs cause a significant left-to-right shunt. The classic auscultation finding is a loud, harsh holosystolic murmur, often accompanied by a palpable thrill, a vibration felt on the chest wall, typically heard best at the left lower sternal border, third or fourth intercostal space.
How are they managed?
Small asymptomatic VSDs, restrictive, can often just be observed. Closure, surgical or sometimes percutaneous, is indicated for larger VSDs that cause significant left ventricular volume overload, often quantified by a QP-Qs ratio 2.0, meaning pulmonary blood flow is at least twice systemic flow. Or if there's a history of infective endocarditis related to the VSD, or if the patient has symptoms like poor exercise tolerance or failure to thrive in infancy. And again, just like PDA, closure is contraindicated in patients who have developed irreversible Eisenmenger syndrome.
Coarctation of the aorta, that narrowing of the aorta, usually just after the arteries to the head and arms branch off. What are the clinical clues?
The hallmark is a discrepancy in blood pressure and pulses between the upper and lower extremities. You'll typically find hypertension in the arms, but diminished and/or delayed femoral pulses in the legs. That brachial femoral pulse delay is a key sign. You might also hear a systolic murmur over the back, between the shoulder blades, due to flow through the narrowed segment.
Any imaging clues?
A chest X-ray might show the characteristic 3 sign formed by the dilated aorta before and after the coarctation, and sometimes inferior rib notching due to dilated intercostal arteries acting as collateral circulation bypassing the blockage.
Are there associated conditions?
Yes, CoA is frequently associated with other cardiac anomalies, most commonly a bicuspid aortic valve, present in about 40–50% of cases. There's also an increased risk of intracranial aneurysms, baryaneurysms, and it's associated with Turner syndrome.
How is it treated?
Treatment usually involves relieving the obstruction, either via balloon angioplasty, sometimes with stenting, or surgical repair, depending on the anatomy and patient age. Lifelong surveillance is needed even after repair.
And the very common patent foramen ovale, PFO, you mentioned it's present in maybe 25–30% of people. It's usually just an incidental finding, right?
That's exactly right. A PFO is that small potential opening, like a flap valve, between the right and left atria that's left over from fetal circulation. In the vast majority of people, it causes absolutely no problems and is just found incidentally if an echo is done for other reasons.
But it gets implicated in stroke sometimes.
Yes, particularly in cryptogenic strokes where no other clear cause is found, especially in younger patients. The theory is that a small clot from the venous system could potentially pass through the PFO during a moment of right-to-left shunting, like during coughing or straining, and travel to the brain.
So how is it managed if found after a cryptogenic stroke?
For patients with a cryptogenic stroke and a PFO, antiplatelet therapy, usually aspirin, is considered first-line medical treatment. Percutaneous PFO closure with a device can be considered, especially for patients who have a recurrent cryptogenic stroke despite being on medical therapy, or perhaps in specific situations like documented right-to-left shunting causing significant oxygen desaturation, platypnea orthodeoxia. But the key takeaway
For asymptomatic people.
for asymptomatic individuals who are found to have a PFO, incidentally, there is absolutely no indication for closure or even routine antiplatelet therapy just because the PFO is there. Treat the patient, not the PFO, unless it's clearly linked to a problem like cryptogenic stroke.
That's really important clarity for so many people who might get worried about an incidental finding. And speaking generally about conditions with Eisenmenger syndrome or any right-to-left shunt, what's that critical safety point about IV lines again?
It bears repeating. Meticulous care of intravenous lines is absolutely crucial in patients with any condition causing a right-to-left shunt, like Eisenmenger syndrome from an uncorrected VSDS-DPDA, or some complex congenital heart diseases. This includes using air filters on IV lines whenever possible and being extremely careful to avoid introducing even tiny air bubbles.
Why is that so critical?
Because, in these patients, venous blood bypasses the filtering function of the lungs. So any air bubble introduced intravenously could pass directly into the arterial circulation, a paradoxical air embolism, and travel to the brain causing a stroke, or to the coronary arteries causing a heart attack or other organs. It's a preventable but potentially devastating complication.
Okay, let's explore pericardial disease, issues affecting that sac around the heart, starting with acute pericarditis, the inflammation of the pericardium.
Right. The key symptoms are typically chest pain, but it's often sharp and pleuritic, meaning it worsens with breathing in or coughing, and classically it's worse when lying flat and improved by leaning forward.
What else might you find?
You might hear a pericardial friction rub on auscultation, a scratchy grating sound with each heartbeat, sometimes having 2 or 3 components. And the EKG characteristically shows diffuse ST segment elevation across multiple leads, often concave up, smiley face, and frequently PR segment depression as well, which is quite specific for pericarditis.
What usually causes it?
It's often idiopathic, presumed viral, but it can also be caused by other things like autoimmune connective tissue diseases, lupus, rheumatoid arthritis, kidney failure, uremic pericarditis, cancer, radiation therapy, trauma, or occur after a heart attack, Dressler syndrome, so less common now.
How is it treated?
Treatment focuses on managing the inflammation and pain. High-dose NSAIDs like ibuprofen or indomethacin are the mainstay. Aspirin is preferred if the pericarditis occurs shortly after a myocardial infarction. Colchicine is usually added to the NSAID therapy and continued for several months, as it's been shown to significantly reduce the risk of recurrence.
What about steroids?
Glucocorticoids, like prednisone, are generally reserved for refractory cases that don't respond to NSAIDs and colchicine, or if NSAIDs are contraindicated, or for specific causes like autoimmune pericarditis. We try to avoid them if possible, as they might increase recurrence risk.
And the more dramatic acute pericardial issue, cardiac tamponade, This sounds like a true emergency.
It absolutely is. Tamponade occurs when fluid or blood accumulates rapidly or in large volume within the pericardial sac, increasing the pressure around the heart to the point where it severely restricts the heart's ability to fill during diastole. This leads to reduced cardiac output and potentially life-threatening shock.
What are the classic signs?
The classic physical exam findings are known as Beck's triad. 1. Hypotension, low blood pressure. 2. Elevated jugular venous pressure, JVP, with distended neck veins, often with a prominent X descent but blunted Y descent. And 3. Distant or muffled heart sounds on auscultation. You might also find pulsus paradoxus.
Explain pulsus paradoxus again.
Pulsus paradoxus is an exaggerated drop in systolic blood pressure, typically more than 10 millimeter Hg during normal inspiration. It reflects the increased interdependence between the right and left ventricles when they're both being squeezed by the surrounding fluid. Inspiration increases right heart filling, pushing the septum leftward, further impairing left heart filling and output.
What does the EKG show?
The EKG and tamponade might show low-voltage QRS complexes throughout, and sometimes electrical alternans, where the height and axis of the QRS complex literally alternates from beat to beat. This is thought to be due to the heart swinging back and forth within the large fluid collection.
And echo.
Echocardiography is key for diagnosis. It shows the pericardial effusion and, critically, signs of hemodynamic compromise, like diastolic collapse of the right atrium, the earliest and most sensitive sign, and right ventricle. Treatment is urgent drainage of the pericardial fluid, usually via pericardiocentesis, inserting a needle into the pericardial space, often guided by echo. And a crucial point: diuretics are generally contraindicated in tamponade, as they reduce preload and can further decrease cardiac filling and output, worsening the hemodynamic collapse. You need volume to maintain filling pressures against the external compression.
What about the chronic version, constrictive pericarditis, where the sac becomes thick and rigid?
Exactly. Constrictive pericarditis is a result of chronic inflammation leading to the pericardium becoming thickened, fibrotic, and sometimes heavily calcified. It effectively encases the heart in a rigid shell, severely limiting diastolic filling of all heart chambers.
How does that present clinically?
Patients often present with symptoms and signs predominantly of right-sided heart failure because the right ventricle is thinner-walled and more susceptible to the filling restriction. So fatigue, dyspnea on exertion, peripheral edema, ascites, abdominal swelling, enlarged liver. A key finding is markedly elevated JVP, often with a prominent Y descent, rapid ventricular filling hitting the rigid wall, and frequently Kussmaul's sign.
Kussmaul's sign.
A Kussmaul's sign is a paradoxical increase or failure to decrease in the JVP during inspiration. Normally, inspiration lowers intrathoracic pressure and increases venous return, causing JVP to fall. In constriction, the rigid pericardium prevents the right heart from accommodating this increased venous return, so the neck veins distend further. You might also hear a pericardial knock on auscultation, a high-pitched sound occurring shortly after S2, representing the abrupt cessation of ventricular filling as the heart hits the rigid pericardium.
How is it diagnosed?
Diagnosis can be challenging. Chest imaging might show pericardial calcification, though not always present. Echocardiography shows pericardial thickening, abnormal septal motion, septal bounce, and respiratory variation in flow velocities. Cardiac MRI or CT can better assess pericardial thickness. Sometimes right heart catheterization is needed to confirm equalization of diastolic pressures across all four chambers, another hallmark of constriction.
And the treatment?
The definitive treatment for chronic constrictive pericarditis is surgical pericardiectomy, stripping away the thickened, constricting pericardium to free the heart. It's a complex surgery. For some patients with transient or inflammatory constriction, a trial of anti-inflammatory medication might be considered first.
So often, heart health extends beyond the heart itself. Let's talk about